Good morning and afternoon and evening to everyone. We're excited to have you back for day 2 and final day of our conference.
Welcome everybody, and welcome to day 2 of the G2MC virtual meeting. I'm Bruce Corfin, will be co-chairing this session on genomics of rare disorders, and it's my pleasure to introduce our keynote speaker for this session, Professor Andrew Sinclair. Andrew is the Deputy Director of the Murdoch Children's Research Institute, the Executive Director of the Victorian Clinical Genetics Service, and a professor in translational genomics in the Department of Pediatrics at University of Melbourne. His full bio is in the booklet, but I think important to mention that he's a leader of the Melbourne Genomics Health Alliance and also the Australian Genomics Health Alliance. He will talk this morning, or whatever time it is for you, about Australian genomics. And I will leave the introduction brief, not to take away from his time. So Andrew, thank you for joining us, and it is yours.
Thank you very much, Bruce. Can I have the first slide, please? So what I want to tell you about today is Australian Genomics, which is a national collaborative research partnership between about 80 different organisations who came together to pilot a whole-of-system approach to integrating genomics into healthcare on federated principles. And I say federated principles because Australia is a federation, so we have to get everybody on board, all the states working together. This was funded by the National Health and Medical Research Council for a very small sum, 25 million over 5 years, but we were able to leverage 120 to about 180 million from partners to actually make this thing work. Have the next slide, please. So the purpose of this was really to provide strategies to government about the equitable and effective delivery of genomic medicine in healthcare, and to ensure that genomic and medical data is safely stored and shared responsibly. That we could build Australia's research and clinical expertise in genomic medicine and enhance our ability to discover new genes, and particularly functional genomics, which I'll come back to later on, as well as drug discovery. We also wanted to advance in this new area of clinical delivery, where patient is actually informed, involved, and empowered with along the whole process. And we wanted to promote ethical, legal, and social responsibility in the application of that genomic knowledge. Next slide, please. So the foundation and vision that we've based this on is that we would have shared leadership around the entire country. So everybody has to be singing from the same song sheet. And that was hard to get that going. There's a lot of lead up in the beginning of this particular enterprise. We need everybody to recognise that we had to change the entire whole system, not just parts of it and not bits of the country. Everybody had to be on board. We wanted to leverage the established centres of excellence that we have in different jurisdictions around the country and build on those. And we wanted to be clear that we were going to be agnostic of the technology. We didn't care whether it was whole genome, exomes, panels, or which company we were dealing with. So, like many countries around the world, we initially targeted, because they're the low-hanging fruit, genomic applications in both rare disease and cancer. The next slide, please. So the Australian healthcare system shown here is, like many healthcare systems, a complex beast. We are a federation made up of many states and a federal government. The feds basically provide all the money, which they then deliver to the states, who actually deliver the services. So they support the public hospitals, and we have a private system as well. So it's a mixture of public and private. But essentially, it's at the state level that's been delivered, and it's the states that are delivering the clinical genomic services. And the next slide, please. So it's comprised, as I said earlier, of about 80 partners around the country in every state. So these are made up of hospitals, of medical research institutes, of universities, everyone with an interest in genomics. That comprised 80 partners. And then we have Australian national partners, the Australian Genome Research Facility, and many others, as well as international partners. But primarily we've worked with the Broad Institute and probably Genomics England as our major international collaborators. The next slide, please. So the approach we've taken is to have 4 major programs of work around and building a national diagnostic and research network, a national data federation and analysis program, another in evaluation of policy and ethics, and a 4th in workforce and education. So that yellow band is meant to be showing the rare disease flagships where we prospectively recruit patients, and the blue line, the greener line below it is meant to be the cancer flagships where we recruited cancer patients in. And a third new line there is reproductive carrier screening. So these are where we prospectively recruit patients and or families. And obviously the outcomes are either to improve prevention and to improve early diagnosis, early intervention, monitoring and precision therapy. But all of this is meant to provide advice to the federal government and state governments about the best policies for implementing genomics into the Australian system. The next slide, please. So this is much more detail of those program and projects. So down the left-hand side, we've got the rare diseases that we've chosen to target, and they range from neuromuscular disorders through to mitochondrial disease and renal genetics. Then down below that in the green, we've got the cancer flagships from acute lymphoblastic leukemia all the way down to hereditary cancer syndromes, which are a variety. The other ones we've chosen, there was a selection process to select those. All those patients are recruited prospectively. And then we've got the 4 areas that we're going to have that are the programmatic areas around the National Diagnostic Research Network. So we built clinical genomic consent across the country. We have variant reclassification and sharing. I'll describe that more later on, and functional genomics. Under the national approaches of the Federation, we now have clinical variant classification and sharing agreed upon, and many other parts of the infrastructure in place. Done a lot of work in evaluation on policy and ethics around implementing this, as we have in workforce and education. And down the bottom, I've got those little dark blue squares. Then we have a national steering committee where everybody comes together. The leads come together quite regularly to monitor this whole process. We have an independent advisory board. We have international advisors. And then down the very bottom, we have a national implementation committee. So this is federal government, Department of Health, and then all the state department representatives as well. So there's a lot of interaction going on between states and feds and the actual program itself. Next slide, please. So, as I said, there's a lot of activity. So in the last 5 years, and this is just some of the numbers from 2019, we had about 102 staff. So that's administrative, program staff, and genetic counsellors as well, who are absolutely crucial in this. As mentioned, we've had just 25 million over the 5 years. We've had about 60 different contracts, 21 clinical projects, 23 sub-programs and sub-projects, 3,000 participants and patients so far. I think that's now blown out to about 4,000. About 450 new collaborations are made. We have now a total of 103 organisational partners, and we have over 1,000 meetings a year with 32 recruitment sites in hospitals around the whole country. Next slide, please. So there's a lot of activity going on. I think one of our greatest achievements, though, is actually to get these clinical recruitment sites in all these major hospitals on board and involved. And we have now consent for all those hospitals ongoing, and agreement that will continue. So we have in the future potential for a single cohort of 25 million people that can be involved with genomic medicine. The next slide, please. So you can see from that we've moved from what was a fairly primitive alliance of people to one where people are now working much more cooperatively together in this large alliance. And you can see some of the work that was done here pre-2016, before Australian Genomics came along, and now the socio-professional network that's been generated, and that's a snapshot of 2018. It's really quite a different scene that we've looked at in that very short period of time, where people are now starting to work together and realise they actually need one another to make this work across Australia. Next slide, please. So across the rare disease flagships we had, and this is consistent with what most people are seeing around the world, we're seeing about a 40% diagnostic rate, but that varied from some 28% to almost 70% in some cases. So it very much depends on the condition that you're looking at. Many of those numbers now have increased substantially since this slide was made. And we've continued with a number of those flagships because they were so successful and the groups involved wanted to continue them, and they've been able to source additional funding to do that. Click one more, please. Amongst the cancer flagships, on average, there were actionable findings in about 45% of cases. And now most of that has gone into routine clinical care for cancer patients, certainly in most of the states. Next slide, please. So overall, some of the outcomes and impacts. As I said, we're very happy that we've got a national clinical genomic consent statement in place, agreed upon. For childhood syndromes and intellectual disability, we had to make the case to the federal government, both a health economic case and clinical utility argument, that they should subsidise genomic tests, and they have now done that for whole genomes, exomes and panels for childhood syndromes and intellectual disability. But we'll have to make that case in each time for each different disease group that we want to go back to them with. For patient and public education, we have a very useful website which has been launched and being used extensively by the public. We have a functional genomics network that's in place now, and various web-based resources, and a data management infrastructure which is now live. Next slide, please. I won't go through this at all because it's quite complicated, but there's this whole workflow which is now in place across the country, which has been piloted and seems to be quite robust and meets all the requirements for what we will need, hopefully, in the future. Next slide, please. So just one of those areas is the shareant or share variants. What this is as a platform set up to share clinically curated variants with structured supporting evidence and phenotypes between Australian labs. This wasn't happening before. And that allows you to have a collaborative view to monitor and look at and curate variants. And having been on an MDT this morning with some 50 people arguing about a variant for a long period of time, those of you that do this for a living will know that this is very important. But also for Australia as a national entity, it acts as a central administrative node for us to then submit that information to international databases such as ClinVar. The next slide, please. The participants that have been involved really want to have much more control over their role in the study and the research. So developed an online tool for their consent and engagement platform, which we call CTRL or control. And this gives participants a granular and dynamic consent options. They can access information, surveys and reports, and gives an option to communicate with the study investigators. Next slide, please. So I mentioned Australian functional genomics. So many of times, of course, we get VUSs coming out of our exomes and genomes, and we need to actually functionally analyse those variants. We've set up a network across the country with about 250 researchers tapping into the clinical groups that are producing the sequence to functionally analyse those variants as they come out. And this is based on the very successful Canadian model that's been in place for some years. Next slide, please. This is just a paper that came out in American Journal of Human Genetics in July last year. I just want to emphasise that it's a federated model for integrating genomics. So we've really tried to involve all the states and the feds to make this happen in a holistic way and change the whole system, not just parts of it. The next slide, please. So this led to lots of different reports being written, and we had, myself and Catherine North had a lot of say in developing these reports. And can you click one more, please? And the upshot of that was that the federal budget in Australia in 2018 came out, and they have now funded us for $500 million for the next phase, which is called the Genomics Health Futures Mission. Next slide, please. So this builds on what we've done, and it's about consolidating our international leadership in this space, investing more in research for better testing, diagnosis and treatment, and improving, delivering rather, genomic testing and targeted therapies as standard of care. Next slide, please. So the simple approach here is a virtuous cycle about improving diagnosis and patient care through improved evidence-based access to genomic testing, building our functional genomics and gene discovery capacity, but also helping Australians benefit from those advances in gene technologies and cell therapies through expanded research and access to clinical trials. One more slide, please. So the new areas, so of course we're going to continue to work in cancer and rare disease, but the new areas we're going to develop are reproductive, infectious diseases, more emphasis on functional genomics, common diseases, gene-related therapy, our indigenous genomics, and greater industry engagement. Next slide, please. So that we've now already started a pilot for national reproductive carrier screening, where we're screening 10,000 couples across Australia for their carrier status for more than 700 autosomal and X-linked recessive conditions. And this is for either pre or early in pregnancy couples. And the research is going to look at uptake, carrier frequencies, incidence, and the decisions that those couples might make. Next slide, please. So I was asked to, if possible, include something on COVID-19 in genomics. So in Australia, we only have about 6,900 cases at total, 98 deaths. You can see that we've flattened the curve pretty successfully, clamped down the borders fairly on, very good testing regime. In some states, the virus has been eliminated now for the last 2 weeks. Next slide, please. But we have a number of large research programs and clinical trials underway, varying from several vaccine trials, to this one around genomics. And the COVID-19 genomics is really about looking at the outliers. So we were very interested in those that are young with no predisposing health issues who appear to have the severe case of the disease, or the very elderly, and I'm talking about over 80, or those who've been hyperexposed to COVID-19 but appear to have very mild syndromes. And so we're looking at doing genomic analysis on those sort of outlier patients. Our big problem at the moment is we've been too successful in suppressing the virus in this country. So we're going to be working particularly with Spain, the Netherlands, and I believe the US as well in this space. I think last slide now. Happy to leave it there.
Well, Andrew, thanks so much. This was really terrific. We are going to there are a couple of questions. I just want to start with a point that impressed me, and I don't know if you would agree with this, but very often we stop and say, well, we can't really do anything without the money. And I guess one interpretation I would put on what you've said is that it did take some funds, obviously, to get this started. But what really sounds like it got it started was the collaboration and the organization, and the real money flowed from that. It wasn't what created that. I mean, do you think that's a fair assessment?
That's a very good assessment of it, Bruce. That's precisely what happened. We had that it was only 5 million a year for the entire country, but it was bringing everybody together and getting our ducks lined up, if you will, getting people to work collaboratively together. And then suddenly, yes, people found money elsewhere to make things happen, but it was getting the alliance together and getting people to agree to a shared vision, which is the great success of it, I think.
Well, there are quite a few questions, and maybe we can handle some of them offline, but I'll read a couple of them, and then I'll have to turn it over to Gert to proceed with the session. One is, can you provide the data and arguments that you use to get the government to subsidize sequencing so that other nations can use it? And I don't expect the question was intended that you would answer that, in 1 minute here, more conceptually, whether you're able to share some of the strategies.
Yeah. We can certainly share that. And it was based around childhood syndromes, which give you the most spectacular results in terms of health economic outcomes and clinical utility. But that was very succinctly provided to the government. Yeah.
And then to hear more about the challenges with engaging and diagnosing rare disorders in indigenous populations.
That's something that's just getting going. There's lots of groundwork, as in many cases, there's lots of groundwork to do with many people involved. I think maybe the Indigenous case here is slightly different because we have literally hundreds and hundreds of different groups, all of which you need to negotiate with. Not a single language, it's different languages in each of those groups. So there's a huge amount of background work that needs to be done on that. We're only just getting that going.
Maybe, I think just for time, we'll take one more question. Say more about the educational activities for health providers and the general public.
So, yeah, so all the states have had also their own genomic programs, but we've had, so for the general public, there's a lot on our websites, and there's been programs that have been done through the universities, but for healthcare providers, we've had hands-on approaches where they've actually been involved with these flagships and getting clinical champions involved with genomic medicine and getting them involved with recruiting those patients and analysing the data. They've been the people who have gone on and then been the champions in their discipline. And we've had many, many courses. The most successful ones are the hands-on, where they come in for an intensive week, or sometimes they've been embedded for months. So they vary in scope and scale.
Andrew, thank you so much. This was a terrific presentation of what I think is an inspirational program. Really appreciate your taking the time to join us today.
Thank you.